Assalamu alaikum. I'm Hani Sabur. I'm a consultant cardiologist at Cleveland Clinic Abu Dhabi, and I'm also a clinical assistant professor of cardiology at Brown University in Rhode Island. It's my pleasure today to be part of your outstanding meeting, and our topic will be the association of SGLT2 inhibitors with cardiovascular renal outcome in diabetic patients. And we'll talk about heart failure and renal outcomes from the CVOTs with a focus on the VERTIS CV study. So I'd just like to start by saying that this statement about diabetocardiology was mentioned by Professor Eugene Braunwald in the keynote speech for the American Heart Association in 2018. And a lot of evidence and changes have occurred since then. But I think it's an important starting point to say that it's very important for cardiologists and diabetologists really to come together to learn about cardiology, to learn about diabetes, and a combined specialty where we all put hand in hand to help our patients proceed with the treatment of diabetes, particularly informed by the outcome studies that we have seen in the last few years. The idea that we wanted to highlight today is that SGLT2 inhibitors affect the spectrum of cardiovascular and renal outcomes, and such efficacy is independent of glycemic control. And at this point, professional cardiology and endocrinology societies and guidelines recommend SGLT2 inhibitors for reduction of stroke, MI, and death in patients with type 2 diabetes and prior ASCVD and or albuminuric CKD. In addition, they reduce the risk of incident heart failure hospitalization in patients with type 2 diabetes, either with presence of CKD or multiple risk factors of ASCVD, and also have a significant impact on disease progression in the kidneys and progression of renal disease in those at high risk for CKD. And as you see from this diagram, the SGLT2 inhibitor trials have evolved greatly and have multiple categories. So the initial category was RCTs that look for MACE endpoints, basically triple point MACE, which is CV death, non-fatal MI or non-fatal stroke, and type 2 diabetes, the initial safety studies. Subsequently, we have RCTs that evolved into primary prevention, diabetes with multiple risk factors and no ASCVD. Then secondary prevention, which is established cardiovascular disease, renal RCTs, which look at diabetics and non-diabetics, and heart failure RCTs, which include diabetics and non-diabetics, both preserved and reduced ejection fraction. So this actually covers the entire spectrum of disease with diabetes. So from CKD as a complication, heart failure, and MACE. Also, we looked at type 2 diabetes and CVD, which is basically seen in the EMPA-REG. And then the subsequent studies were type 2 diabetes with CV risk factors such as DECLARE and CANVAS. There were primary prevention groups. And as we've seen recently, DAPA-HF, EMPEROR-reduced, as well as EMPEROR-preserved have been recently published for heart failure only with diabetes and non-diabetes. And now we have dedicated CKD studies with and without diabetes. So we've seen Credence been published, DAPA-CKD, and we're waiting for EMPA-Kidney and SCORE. So now we've evolved the full spectrum of SGLT2 clinical studies. And in terms of heart failure, the SGLT2s in heart failure have gone from heart failure prevention, which is very robust data from the CANVAS program, Credence, DECLARE, and EMPA-REG, over the preclinical stages of disease to heart failure studies in diabetes and non-diabetes patients with DAPA-HF, DELIVER, EMPEROR-preserved, and EMPEROR-reduced. Now, it's also quite obvious that SGLT2 inhibitors are actually heart failure and CKD drugs. These SGLT2 inhibitors have modest glucose lowering, but very beneficial effects on cardiovascular outcomes in different populations. So patients with type 2 diabetes and heart failure and kidney disease, heart disease and diabetes, and of course, a combination of all four. So as kind of a summary, I think we can say now in 2021, the SGLT2 inhibitors are essential evidence-based therapies in all of the following groups. Essentially in all diabetics to reduce cardiovascular disease, heart failure, and CKD. In actually all heart failure patients, HFrEF and HFpEF and mid-range ejection fraction to reduce hospitalization. In all CKD patients to reduce cardiovascular death. And in addition, All of this, regardless of the presence or absence of diabetes, regardless of the presence of A1C elevated or not, regardless of GFR, and in fact, regardless of EF. So there's really an entire spectrum of patients that really have a tremendous benefit in terms of diabetes and organ complications of that. And this shift has become a central one. So SGLT2 inhibitors are no longer just a drug in patients with diabetes to be compared to others, but rather a central therapy that lowers the risk of cardiovascular events and renal events. And now, since 2019 and going onwards with all of the guidelines, preference to the glycemic control agents that reduce cardiovascular disease or heart failure and CKD as well. And the efficacy of the SGLT2 inhibitors is seen even when the GFR is below 30. So the glycemic effect is reduced, but the cardiorenal benefits are still very clearly seen. And we know that the SGLT2 inhibitors are hemodynamically active. They have anti-inflammatory properties. And as George Bacris, the former president of the American Society of Nephrology, SGLT2 inhibitors are cardiorenal risk-reducing agents that have glucose lowering as a beneficial side effect. So with that, we're going to delve a little bit into the VERTIS CV study. So this is the cardiovascular outcome study with ertugliflozin. And this is a multi-center randomized prospective double-blind placebo-controlled event-driven study where the endpoint was non-inferiority. The composite outcome was triple-point MACE, CV death, non-fatal MI, and non-fatal stroke. And the secondary endpoints was a composite outcome of CV death and heart failure, CV death alone, or renal composite, which was renal death, dialysis, or doubling of serum creatinine. The inclusion criteria were fairly straightforward and quite similar to the other CVOTs. Age over 40, type 2 diabetes with an A1C between 7 and 10.5, established ASCVD in all the patients, including coronary, cerebral, or peripheral vascular, and on background therapy for at least 8 weeks, or some of them were actually treatment naive. All ketoacidosis type 1s were removed, recent myocardial infarction within the initial screening phase or cardiac surgery, and a GFR less than 30. In addition, marked functional class 4 heart failure was excluded. Now, one important point to remember here is the definition of ASCVD comes from the ESC guideline for definition. So these patients either had to have a myocardial infarction recently, coronary revascularization with PCI and CABG, or a history of ischemic stroke, non-hemorrhagic, or revascularization of the carotid, or carotid or peripheral artery disease with a resting ABI of less than 0.5, or a prior amputation, peripheral bypass, or peripheral angioplasty. So documentation of peripheral vascular disease. And they took this primary endpoint as the number one endpoint, CV death, MI, or stroke. The second was a composite endpoint of heart failure and CV death. And these were hierarchical. So one had to be met before you could go into the other. And then finally, the renal endpoint, as you're very familiar with. The baseline characteristic is that 99.9% of these patients had established cardiovascular disease. Majority had coronary artery disease, half had an MI or revascularization. Heart failure was 25%. This is much higher than the other three randomized clinical studies of SGLT2s. And of course, a distribution of PAD, cerebrovascular, and stroke. The baseline cardiovascular medications were, as you might expect in a group of patients with established ASCVD, almost 85% with platelet inhibitors, high-intensity statin with ezetimibe, RAS blockers and beta blockers in the majority of patients. So a very robust background treatment therapy. Now, of interest to the diabetes information is that the metformin was the commonest baseline drug, with insulin and sulfonylureas coming a close second, and the minority DPP4 and GLP-1 receptor agonists. The endpoint, as you see here, was that the ertugliflozin compared to placebo was non-inferior. Not superior, but non-inferior, but CV death trended in the right direction. Non-fatal MI was identical and non-fatal stroke was unchanged. However, when you looked at the secondary adjudicated endpoint of cardiovascular death or heart failure hospitalization, there was a significant reduction, 11%. However, the p-value did not mean superiority endpoint. Cardiovascular death was essentially identical to placebo, but it was actually numerically less. But the most incredible benefit, which we have now seen across the board in all SGLT2 studies, was almost a 30% reduction of heart failure hospitalization. And this was statistically very significant. And these curves diverge within months of the enrollment. The renal composite endpoint is, as you see here, lesser than placebo by 19%. But remember, the composite endpoint included doubling of serum creatinine, which, as you see, is different and a little bit more rigorous than the other clinical studies. However, the renal stabilization, as you see, is quite profound, and you have the initial hyperfiltration dip and then a stabilization of the decline in GFR compared to placebo, a very significant difference in terms of renal function stabilization. The secondary endpoints, as you see here, the heart failure hospitalization is of great benefit and great significance, both for inferiority and superiority. Adverse events leading to discontinuation were actually no different than placebo. And the selected adverse events, such as urinary tract infection, genital mycotic infection in females, was significantly increased, which is not unusual, but symptomatic hypoglycemia, hypovolemia, and pancreatitis were not. Important special interest safety events, which are reported to the FDA and tracked: acute kidney injury was also less than placebo. Amputation was unchanged, no significant difference. Diabetic ketoacidosis, fractures, and fournier gangrene, no different than placebo. So the risk of the amputation, and these are lower extremity amputations, usually small lower extremity amputations, were no significant difference by statistical analysis. Now, acute renal failure, as we just saw, was reduced in the ertugliflozin arm. Now, we'll try to focus a little bit on the heart failure related events from the VERTIS CV study. So we've been through the baseline characteristics, but I'm going to point out to you the percentage of patients who are normal albuminuric versus micro and macroalbuminuric. The majority of patients had no microalbuminuria at all. And this is the distribution by ejection fraction. And this is quite unique because this is the study that ejection fraction was not only calculated, but it was specifically reported. And this is also very important because about 25% of these patients actually had heart failure. And the utilization of guideline-directed medical therapy in these patients with HFrEF, 90% ACEs and ARBs, and patients with all heart failure, 85% ACEs or ARBs and beta blockers. So very robust heart failure therapies. So the cumulative incidence of first and recurrent heart failure events compared to placebo with ertugliflozin was significantly reduced. And recurrent heart failure is very important because, as you know, patient with heart failure doesn't just come to the emergency room once, they keep coming back, and really you want to see if it affects incident heart failure, new onset of heart failure, or prevalent heart failure as well. In fact, you see the impact is almost identical, 30% here and 30% there, with a very early divergence of the curves. The time to first heart failure by dose, no significant difference. Both the 5 milligrams and a 15 milligram dose, and compared to all patients, was significant as well. In addition, if you compare to the patients who had a prior history of heart failure versus a patient who did not have a prior history of heart failure, while the impact is greater, it still has an impact in terms of favoring the active treatment arm. Whether the ejection fraction, when it was lower, less than 45%, there was a greater benefit, almost 52%. But even when the EF was slightly higher, what we call HFrEF or mid-range or unknown, again, significant reductions in heart failure overall. So across the board, but even more effective in the lower ejection fraction patients. And if you looked at the baseline and pretrial ejection fraction, again, this stands true. Now, obviously, the patients with lower ejection fraction had a greater magnitude of benefit, but the p-value of interaction was not significant, meaning that all groups benefited as well. Now, did the heart failure have any change based on the GFR? So actually, if you looked at the presence of GFR and microalbuminuria, those patients who had a lower GFR actually had a 50% reduction of heart failure. Those patients with micro and macroalbuminuria, again, had an almost 50% reduction of heart failure. The use of diuretics, and particularly loop diuretics, seems to have an impact because obviously those are patients who have clinical hypervolemia as well. So the augmentation of the effect with the SGLT2 inhibitor was quite robust. And if you combine this with the heart failure and CV death, which was a pre-specified analysis already specified prior to the study end, you can see that the combined endpoint is significantly reduced by 17%, and heart failure alone is 30%. So, and in fact, it also looks here at initial events in blue, second events in green, and third events in the orange arm as well. So the meta-analysis of the SGLT2 inhibitors is also very instructive. And I'm going to remind you that in the original EMPEREG outcome study, CANVAS and DECLARE, the total number of patients in these studies with ejection fraction less than 40% and heart failure was only 10%. In the VERTIS CV study, there were actually almost 24% of the patients had clinical heart failure and their ejection fractions were identified. So summarizing the important CVOTs, you can see here that in terms of heart failure hospitalization, the EMPEREG outcome study, CANVAS, DECLARE, and VERTIS, all of these had a significant and clinically robust reduction of heart failure hospitalization ranging from 30 to 35%. In terms of MACE, the EMPEREG and CANVAS programs had a 14% reduction of MACE that was significant. VERTIS CV had a 3% reduction, not significant. And CV death was seen in the EMPEREG outcome study with a 40% reduction of significant reduction in CV death. Now, it is very important to realize that after the analysis of these studies, it is the MACE reduction is seen only in patients who have had a prior major cardiovascular event. And with that, if a patient only has established CVD but not a prior MI, the expectation of reduction of a myocardial event is attenuated. Now, this is sort of a comparator of all of the clinical studies in one slide. So the largest, of course, is the DECLARE study, and this also included patients who did not have established ASCVD. Only 40% had CVD. But you see here the difference I'm trying to highlight is that heart failure in the 4 initial studies were basically 10 to 14%, VERTIS CV 24%. The reduced kidney function arms were somewhere between 20 to 20% in the 3 major studies, but the CREDENCE, being a renally focused study, had 60% of patients. Now, if you take all of the studies together, again, the meta-analysis shows very clearly that whatever the agent, heart failure hospitalization was significantly reduced and a very robust 30 to 35%. Now, whether the patient had ASCVD or not, this was very important. This is important to analyze. And in fact, heart failure, again, is reduced whether they have coronary artery disease or do not. The renal composite endpoint was also markedly attenuated in all of these studies. And that means that you have a cardiac heart failure benefit across the board. You have a renal benefit across the board. And the ASCVD benefit is limited only to patients who have had a prior myocardial infarction. Now, the renal outcome is very important, and I think it's very important to discuss the definition. In VERTIS, they took a very difficult definition. They took renal death, dialysis transplant, or doubling of serum creatinine. And here, while it is numerically less, it appears to be statistically not so, except towards the end of the study by month 36 when the curves diverge. However, the pre-specified endpoint was actually included the other definition, which is called a clinical definition or modified endpoint, the 40% decrease in GFR and progression of microalbuminuria and change of GFR over time. Now, kidney categories are actually quite complicated. And just to remember that in the VERTIS CV, The patients that were enrolled were patients with a GFR less than 30 were not included in VERTIS CV. However, there was a big range of patients with albuminuria as well as GFR between 60 to 45. So it encompassed a wide range of renal outcomes. And there were patients in CKD stages 1 to 3, normal and microalbuminuric, very high risk and low risk as well. Now, if you took the actual original endpoint, which is doubling of serum creatinine, the event rate is reduced by 19%. If you took sustained doubling, so persistent worsening of renal function, there was actually a 35% reduction, which just didn't meet the statistical significance. On the other hand, the commonly used clinical reduction of 40% reduction of GFR, 66% reduction with a significant statistical p-value. And I think this is the important endpoint which we use in the other clinical studies, such as DECLARE as well. Because, of course, you're not really going to wait for the kidney function to become 50% and go to dialysis before you have some clinical impact. So the reality is, if you take a more clinically oriented endpoint, there is a clinical difference, and you see the separation of the curves at 24 months and continues to do so towards end of study. When you take the 40% decline plus transplant or death, here, whatever the category, if CKD stage 1, 2, or 3, there is a reduction. The greatest reduction, in fact, the greatest number of patients was in CKD 2. Whether you took the urine albumin creatinine ratio, a normal albuminuric, micro or macroalbuminuric, again, there is a sustained improvement in the 40% reduction of GFR. And using the KDIGO CKD risk categories, again, all groups of patients benefit as well. Albuminuria becomes very important. There is clearly an attenuation of albuminuria in the overall cohort, and it goes to the pooled group of almost 23% compared to placebo. The progression and worsening of CKD by any kidney function category, either micro or normal albuminuric or normal or CKD risk, again, significantly reduced compared to the placebo arm, clearly. And more patients actually had regression of albuminuria with the ertugliflozin as a whole, 21%, than with placebo. This is a kind of an important concept. And of course, you've seen this before. That is the flattening of the albuminuric curve. It's lower with the ertugliflozin than placebo. And the time to change of GFR and UACR. So it's clearly nephroprotective, and we've seen this previously, that the slope of decline in the placebo is 2.5 ml per minute per meter squared per year, and flattening of this means that there is protection of the kidney over time. So summarizing the kidney outcomes of the various definitions of renal function, the doubling of the serum creatinine was utilized in the the EMPEREG outcome study and VERTIS CV, and the CANVAS and DECLARE programs use a 40% reduction. If you take the doubling, then there is, of course, renal benefit, but it doesn't meet statistical significance. If you use the more conventional approach of a 40% decline, then there's actually a 40% reduction across the board for all the studies, indicating a significant renal protection. Now, why is a cardiologist talking about renal outcomes? Because we know that renal outcomes are tied to CKD, cardiovascular death. By using a conventional standard approach of a 40% reduction of GFR plus the dialysis or death from renal causes, you see here that across the board, all of the SGLT2 inhibitors provide a very robust reduction. But when you have protection from renal worsening, we know that 5 times death in patients with CKD occurs due to cardiovascular death and not due to renal failure. So I think it's very important for me as a cardiologist to realize that if I have an agent that protects from heart failure and protects from renal failure, I'm getting a double benefit, because ultimately these patients will die of cardiovascular death and not due to renal-related complications as well. So in conclusion, I think we can say that the VERTIS CV achieved the primary endpoint of non-inferiority for MACE compared with placebo in patients with diabetes and established ASCVD. There is significant evidence from the VERTIS study that the CV safety of cardiovascular SGLT2 inhibitors across the board in terms of heart failure and renal endpoints in the class. The agent was associated with a decrease in the sustained 40% decline in GFR and less albuminuria and more GFR preservation over time. The CV safety data do not alter the estimates of risk for any specific safety events. They're basically all identical in terms of amputation and peripheral artery disease. Meta-analyses support the current society recommendations to prioritize the use of SGLT2 inhibitors independent of glucose control in patients with diabetes with high risk or at kidney disease as well. And I thank you for your time and your attention.